Good afternoon, everybody. Assalamu alaikum wa rahmatullah. I welcome you all to our wonderful symposium for Urgo. And just feel comfortable, grab your lunch, and we will go with the flow. So just to introduce our symposium today, my name is Gulnaz TARIQ. I'm the president for World Union Wound Healing Society. The main aim is you feel comfortable and you enjoy every session. So today with me is Professor Madeleine FLANAGAN. She's a program director from University of Hertfordshire, and she will talk to us today about evidence-based practice. So please welcome Madeleine FLANAGAN. And our second speaker for today is infection diagnosis and risk. She will talk about that. It's Professor Valerie Edwards. So please welcome Professor Valerie. Our third speaker for today is Mariam ALESSA. She will talk about winning tool, and that will be our symposium today. So we will go through all these presentations, and then we will have Q&A at the end before we start the video. So stay relaxed, enjoy the talk, and prepare yourself for Q&A. Thank you very much. So as you know, this symposium is to help your diabetic foot ulcer patients and getting them back to their life sooner, because you know the prevalence of diabetes worldwide is getting as a pandemic. So we need to really do something to overcome with this challenge which is coming in the future, and we need to prepare ourselves for that. So these are the panelists I have introduced to you already, so you are free to ask them questions at the end. And once we finish the session, you can grab them and have one-to-one discussion with them if you want to know more about DFU and all these related factors which are for diabetic foot ulcers. So what kind of patient do you have at your waiting room where you are treating them for diabetic foot or prevention, education, and dealing with one-to-one patient? That is very important, how your dressing room or how your patient waiting room looks like. So I really feel comfortable where my patient is sitting. He has the visual cues, like visual leaflets where it's just speaking by itself when they are sitting and waiting for their appointment to be seen by the doctor. So visual charts, visual leaflets, that is self-explanatory, easy to understand in different languages, that can really play a role. So you have seen the highlights of the Middle East region is the prevalence of diabetes mellitus is really very high. So we really have to think about it from now just to see where we are heading to in next 10 years. So if we focus on prevention, this is where we will have a big success in saving the limbs of our patient. So prevention is a strategy, and that is what we have learned for last 2 years from COVID. So COVID prevention, again, you are all with mask today. You're washing your hands frequently, distance, but this is what we need to do for diabetic foot ulcers as well to prevent our patient from losing the limbs. And you have seen that in 3 people living with diabetes in the region are undiagnosed, so they don't even go to the family physician to check what is their regular health care or their, what is their blood HbA1c and all. So we need to teach our community that it's very important to go back to their family physician and have regular checkup. So at least every 3 months, if they do their blood test, and then they know if there is diabetes, early detection, and then prevention, to put them on a pathway where we can prevent all these. So we can only, work on reducing the number is if we are all speaking the same language. if we are aligned, if we are all working together. And I can see big experts here who are involved with diabetic foot and diabetic associations, so we have to really check the website and see what are the latest guidelines and to get it from there. So prevention of ulceration, and then close wounds sooner. So healing, also, you need to collect your data where you're working. So what is your prevention data says, and what is your prevalence says, and how you can heal the wound, and what could be the time frame for that. So with that, I invite Professor Madeleine FLANAGAN to talk to you about her topic. Please give her a round of applause. Thank you.
Good morning, and thank you. It's lovely to see so many of you in the room. In my session, I'm going to take a closer look at the evidence base supporting the use of sucrose octasulfate dressings in the management of hard-to-heal diabetic foot ulcers. And because that's quite difficult to say, I'm going to refer to the dressing as SOS from here on. So before we do that, let's refresh our understanding of what the term evidence-based practice actually means. And I think, from my point of view, it's important to emphasize that it's not just about looking at the research evidence. We do need to have critical appraisal skills to do that, but we need to look at the implications for research. What is the relevance of this research to our own clinical practice? That affects clinical judgment, and our patients' wishes, our patients' preferences have to be taken into consideration on an individual basis as well. And that's your role as a clinician. So evidence-based practice is, for me, very clinically orientated. It's not just a research exercise. So why do we need research? Why do we need to consider the evidence base? Well, I think one of the key issues is that we do need to standardize our care. And we're focusing in on the management of diabetic foot ulceration during this presentation. So we need to look at the key stakeholders. Patient obviously comes number one, ourselves as clinicians, but it is also looking at administrators and other caregivers as well, and the policymakers. And we need to consider patient safety and clinical effectiveness. Those are two of the most important elements. But as I've already said, the patient preference is important in all of this. So you can see the different elements that are important in the clinical decision-making process. So we need to make sure that whatever treatments we're using are up to date and are reflecting the current research findings, the current evidence base. And the key elements of that is looking at the efficacy. Is the treatment that I'm using the most effective treatment that I can use, rather than always saying to ourselves, we've always done it this way. So you can see on this slide the different elements in that decision-making process. And what we're going to stress today is there have been lots of exciting developments in terms of the evidence base in the last 10 years. But sometimes as clinicians, you're very busy. It's very difficult to constantly be reading the literature. So we're going to summarize some of those key findings. But it's important to recognize that not all evidence is equal. There are different types of evidence, and different types of evidence is used to demonstrate the different types of research questions. So we need to be able to make a judgment about the quality of different types of evidence, and that can be difficult. That may need us to actually go back to school, if you like, and improve our critical analysis skills. So I'm going to highlight some of these points very, very quickly during my presentation. Now, most of you will be very familiar with this triangle, the pyramid of evidence, and it's a hierarchy reminding us of the different types of evidence and the quality in terms of proving treatment efficacy. And the types of studies, and I've sort of highlighted them, I haven't got time to run through this on the slide, but I've highlighted the different types of evidence base that you will be familiar with. Those at the top of the triangle are the higher quality types of studies. They're better designed, and as a result, they have a lower bias. And as you go down through that hierarchy to the bottom, and you'll notice that expert opinion from people like us, experts and experienced clinicians, comes at the bottom of the evidence hierarchy. That doesn't mean it's of no value. This is very good for sharing best practice, but in terms of looking at treatment efficacy, it's not quite as robust. And most of the clinical trials that we see in wound care are non-comparative clinical trials, and these are there to demonstrate safety rather than effectiveness. And it's the RCT that really, in terms of treatment decisions, determines the clinical effectiveness. And we're going to look at an RCT in a moment. The good news is we do know how to look after diabetic foot ulcers. In the last 20 years, there's been a growing body of evidence building up, so we do understand the principles of diabetic foot management, and these have been pulled together in evidence-based recommendations made by groups such as the International Working Group on Diabetic Foot. So although we're talking about the use of dressings and local wound management in this symposium, we fully recognize that the treatment of diabetic patients starts with metabolic control. We need to have vascular assessment and management of that limb. We need to have local wound management, debridement and management of infection. And Valerie is going to talk about that immediately after me. And of course, offloading is very important. So it's a whole package. Now, if we return to the hierarchy of evidence, what I'm hoping to show you on this slide is how Urgo have worked tirelessly to put together a robust sort of evidence sort of package, if you like, and they have produced papers that go right from the systematic review at the top, including randomized controlled trials, which are important for looking at efficacy, right down to clinical-based guidelines and clinical practice. And Mariam is going to talk about that in the last part of the symposium. There's references here, and there's references available at the end of the presentation, and if you want to pick up papers or discuss the details of any of these studies, please go to the Urgo stand at the end of the presentation. So what I'm going to do is highlight some of the key messages from one of the most important randomized controlled trials, looking at the use of sucrose octasulfate dressings compared to a neutral non-active dressing. And as you would expect, you can see on this slide an outline of the design of an RCT. So this is a study with 240 patients. That's quite a large study in wound terms. And the most important thing, you can see the entry criteria on the slide here, but one of the most important things to highlight is that this study actively sought out patients with neuroischemic wounds. These are the most difficult to heal group, and so the findings of the study are actually quite important, bearing in mind the clinical difficulty. And you can see some of the pictures there of the types of wounds included in this study. These wounds were recruited in France, Spain, UK, 5 countries in total, and they're very similar patients to your own patients. Now, what's important, you've got an active treatment group with the SOS dressing compared to a placebo dressing which looked exactly the same and was put into boxes and packets that looked exactly the same as the active group. So the researchers didn't know the difference between the two. The patient's care was standardised, so the cleaning of the wound, the local management of the wound, the offloading of the wounds was exactly the same, and that's what you're trying to do with an RCT. You're trying to keep everything the same apart from the active dressing in this case, because you're trying to demonstrate the difference between the two arms of the study. The clinical outcomes in this case, the primary outcome was looking at wound closure, and the secondary outcome was time to wound closure. So, and this is a slide that really speaks to me from a clinical perspective. So here we are, we're looking at the primary outcome. So this is looking at this is looking at wound closure. And you can see immediately that the graph is demonstrating here that if you look at the total population, that's 240 patients, in the non-active, the control group, some of those patients healed, 30% of those patients healed. And in the active treatment, in the SOS group, 48% of those patients healed. So that's a good finding, first of all. But when we analysed the results and looked at those patients that had had the dressing put on under 2 months, so early intervention, the findings were quite startling. And you can see in the middle graph there, sorry if I just, oops, I've pressed the wrong button there. Sorry. In the middle graph there, you can see how you've got a much greater healing rate where you're putting the dressing on under 2 months. Again, if you look at this graph here, if you leave your treatment, you don't assess the wound properly, and you put the treatment on, this active treatment, after 11 months, you do get increased healing, but that difference is very much reduced. So the key message here is that we need to assess the wound, and we need to get the intervention, the SOS dressing on early to get these increased results. And this 20 weeks is 5 months, which is again a realistic time in terms of our clinical management of diabetic foot ulcers. The secondary outcomes are also impressive, and both of these outcomes, you may have noticed on the previous slide, both of these outcomes were statistically significant. So that means that those results did not happen by chance. If we look at the secondary outcomes here, we can see that we're getting complete wound closure 60 days early in the intervention group. So what does that mean for patients? Well, that means for a patient that my diabetic foot ulcer heals 2 months earlier than it would be with an alternative dressing. So that's really important for the patients. So the message here is that when you use a sucrose oxasulfate dressing and you add it to your standard diabetic foot ulcer management, then you will get reduced healing time, and that is proven by these studies. So this slide is to remind me again that the evidence that I've presented to you and just highlighted the key messages here is about the local treatment of the wound. This is a small part of our overall management of the diabetic foot ulcer patient. So we need metabolic control, we need assessment of the patient and the wound, we need to monitor the healing. Most importantly, we need to assess and understand the type of wound that we're dealing with, and we need to get the SOS dressings onto the wounds early, and that's going to potentiate and increase the healing rate that you're going to actually achieve. So it really is time to implement the evidence that we've got. We moan a lot in wound care that there's not a lot of evidence available. But I think sometimes we are guilty of not keeping up to date with the evidence. We're not necessarily reading and interpreting that evidence and using it to change our clinical practice. So I would just really like to finish by saying that What I've tried to do very quickly in this session is to summarize and give you confidence that you can use sucrose oxysulfate dressings with confidence, because they're recommended by independent bodies such as the International Working Group for Diabetic Foot Management and NICE guidelines, which are clinical guidelines in the UK which actually support healthcare treatment decisions. On top of that, we've got clinical evidence, we've got randomized controlled trials that have been properly conducted that are statistically significant, and there is a wealth of clinical experience, as Mariam is going to show us in the final segment of this presentation. So my take-home message to you is that we've got the evidence. We need to now start using that evidence and implementing it to improve the care of our patients with diabetic foot ulceration. Thank you very much. Thank you.
Thank you. Good afternoon, and thank you all for attending. I hope you find this session extremely informative, and we've tried to pull together evidence with knowledge base and expert opinion to give you some way forward in the diabetic foot ulcer management. I'm going to talk very briefly today about diagnosis of infection in the diabetic foot, but also how you can manage it going forward. Unfortunately, the diabetic foot is absolutely conducive with infection. We've had studies undertaken on many chronic wounds, including the diabetic foot, and we find that over 80% of all chronic and diabetic foot ulcers are colonized and infected with a whole range of microorganisms. They tend to grow in biofilms. Biofilms are firmly adhered to the tissue, and this makes eradication of these infections or gross colonization very, very difficult for you as practitioners. What we do find is that the environmental conditions, such as moisture, dead and necrotic tissue, are ideal for the organisms to survive. And what we have to do is try and change the environment and allow the wound to undertake its natural healing process and go on to healing. Therefore, in nearly all chronic wounds, biofilm-based wound care is advocated. And what we mean by this is removal and traumatizing the actual biofilm, which is a complex matrix of microorganisms, predominantly bacteria, living together underneath a matrix within and sitting on the wound bed. This is an invisible thing, but you may see slough and other dead and necrotic tissue as it establishes itself. Biofilm-based wound care is a physical thing that you should do, and it's based on debridement, cleaning, and application of an appropriate dressing to maintain reduced numbers of microorganisms so natural healing can continue. In that slide, I'll just go back, which I wanted to mention. In that slide, you will see I've highlighted the guidelines from the International Working Group of the Diabetic Foot. They have had guidelines available for many years now. They've just been recently updated in 2019. And there's 27 recommendations in here to help with the diagnosis and treatment of diabetic foot infections. So if you haven't read that, you should do. Not all recommendations will apply to your individual patient, but certainly most of these recommendations should be included in your national and local policies. So what's the most serious complication of the diabetic foot? Well, it's infection. And what we find with infection is that we can see usual indicative parameters of infection without actually having to have it diagnosed conclusively by the laboratory. So these are things like increased wound temperature, a change in pain and pain threshold, and if you've got a neuropathic foot, obviously it might just be a change or a feeling of a difference within the foot, redness, increased exudate, malodor, and erythema around the tissue. And these are very, very common factors that you see. Not all factors have to be present, but we do find with a local infection, you usually get greater than 5 factors in a chronic wound that will indicate that you have a local infection. And it's very important in the diabetic foot with a local infection to deal with this. And certainly within these guidelines, they've categorized infection into mild, moderate and severe to help you with your decision making. If you do have a very severe infection of a diabetic foot, and I've had most of my colleagues laughing last night because I am extremely squeamish and I faint very easily, so they've just got this one picture on here of this diabetic foot. I'm sure you must see something far worse, but I've got something that I can handle looking at this foot. So, there are 4 categories within the guidelines. Category 1 is no infection, and here you as practitioners would instigate standard treatment. Remember that in 80% of all infected wounds there is a biofilm, and biofilms can build up at any time. You will have within that diabetic foot definitely microorganisms present. It's whether or not they cause a local infection. So within your standard care, you do need to be thinking very carefully of the dressings you choose and the cleaning you use and debridement. And they are the 3 key elements of your diabetic foot management. A mild infection will have no systemic manifestations whatsoever, but you will see some local indicators, these local parameters of the 6 I mentioned, redness, heat, etc. You shouldn't see anything else major, and these would be classed as mild. And for something like this, you would do debridement, cleaning, and choose an appropriate topical antimicrobial dressing for your patient. With a more moderate infection where you may well have it going into a larger erythema, you may have other things involved with tracts and tendons. Well, in that case, you still need debridement, cleaning. You will certainly be choosing a very good topical antimicrobial dressing for your patient, but you should also then consider the use of antibiotics. Not topical antibiotics, but systemic antibiotics. And obviously with a very severe infection where you've got tendons exposed, exposure to the bone, possibly osteomyelitis, systemic antibiotics must be considered, and they must be given as quickly as possible. Systemic antibiotics will vary depending on your local policies, but they typically include something like clindamycin if it's a soft tissue infection, although you have to be aware of something like Clostridium difficile, or you may well have a beta-lactam, but your policy will determine based on the organisms that you have in your local area and whether or not they're multi-drug resistant. I often get asked about swabbing and taking samples, and that's very, very different in different countries. In some countries, we rely on swabbing, certainly in the UK, and that's primarily because the laboratories don't really have the facilities to deal with curettage or wound biopsies, whereas in other countries, wound biopsies are key. So what's the general principle for infected wound management? First, you assess the wound, you assess the patient, and it's holistic. Then you will assess the severity of the infection and categorize it as such to help make your decision. So looking at the various parameters, you will take optimal specimens at that time if you do routinely take specimens for the laboratory. But one thing I must emphasize, if you take any specimens whatsoever, it has to be after debridement, cleaning, and then removal of any antiseptic if you've used an antiseptic cleaning agent, and then you take your sample. A swab is okay, but you will only get a sample of what's on the surface, and obviously with a wound biopsy you get more in-depth information. Then you need to think about timely surgical intervention for your patient, and then look at also the appropriate use of systemic and topicals based on your local policies. One of the things I've always been very, very passionate about is the development of antimicrobial resistance. And unfortunately, I can see the dilemma you're in as practitioners, because if you have a patient with an extremely infected foot, you want to give them systemic antibiotics to try and prevent the loss of that limb. However, with the advocation of antimicrobial stewardship and antimicrobial resistance, you must think, does this patient really need antibiotics? Or can I help this patient? Can I get rid of this local infection with really good wound management? Debridement reduces bioburden by at least 1 to 2 log. Cleaning will do the same, and then the application of a good topical antimicrobial agent will keep the bioburden down. If obviously the patient's got moderate to severe infection, he will need antibiotics, and the cover for this is usually 1 to 2 weeks and then up to 3 to 4 weeks if it's deemed necessary. Systemic treatment. You usually, if you are going to use the laboratory, you will use empirical treatment, which can be something like a beta-lactam antibiotic, and you would use that until you get your results back from the laboratory, and then you would go on to narrow treatment. You would stop the use of antibiotics when they are unnecessary, and also when you're looking at the choice of dressings, which I have on the next slide, what you would think about is how frequently am I going to change the dressings, and when am I going to stop using antimicrobial dressings? Because it's all right to use them, but you do have to have a plan. You have to assess the wound, debride and clean, apply your topical antimicrobial dressing. If after 2 weeks that you have been doing this, you see no improvement and no change, think about changing the topical antimicrobial dressing. It might be that it just doesn't suit your patient. But if you've got a good topical antimicrobial on the wound and the wound is healing and you still feel it needs that, then assess it. Keep assessing it. However, once the wound is on the trajectory of healing, you should withdraw the antimicrobial agent and just go back to standard dressing practice. Once the local infection is gone, go back to standard practice and stop using the antimicrobial. We don't want antimicrobial resistance developing in dressings. So we have a very infectious cycle. A vicious cycle causes exudate, slough, and these are all ideal growth conditions for your microorganisms. So you will get infection potentiating based on biofilms that sit nicely within the wound. So you always want to be thinking, I must try and get rid of this biofilm. And when you do disrupt through debridement and cleaning, you have a 24-hour window, really, of trying to destroy that biofilm. So application of a topical dressing will help because it will reduce numbers. So how can we stop this vicious cycle? Well, we look at another evidence-based piece of dressing from Urgo, and this is Urgo Clean AG. What we have in this is fibres of the dressing is very, very good at attracting microorganisms and slough, and that will hold that within the dressing. It also has silver within the dressing, which, as you know, is a very good antimicrobial, so it will kill microorganisms in the dressing, and it's also been proven to have antibiofilm activity. So if we look at the pyramid of evidence again, you can see there is evidence for use of Urgo Clean AG all the way up. And at the bottom, you can see there's a number of laboratory-based studies that's been done, which I just want to share very briefly now. So if we look at the antibiofilm activity test, this was done on a biofilm made in the laboratory of MRSA. It was grown up, it was mature, 24 hours. Urgo Clean AG was placed on this biofilm up to a period of 7 days. And obviously the dressing was removed and the numbers of organisms remaining were counted. And what we saw, if you can look at these two pictures down here, This is the untreated biofilm. This is what it looked using the microscope, and this was what it looked like after 24 hours contact with Urgo Clean AG. And it was demonstrated there was a 4-log reduction in numbers. Now, if you think you've debrided, you've cleaned, you've got a 4-log reduction when you apply Urgo Clean AG, the numbers of microorganisms left in that biofilm is minimal. And wound healing will occur, and it's all based on numbers. So if you can reduce bioburden, and you're using an antimicrobial dressing, the lower the bioburden, the better the dressing will work. So Urgo Clean AG has proven ability to reduce bioburden. And in a second test with a silver comparator, which is very, very widely used, it was shown on biofilms of Pseudomonas aeruginosa and MRSA that we had a 4-log reduction in bioburden within a 24-hour period using Urgo Clean AG compared to a 2-log reduction with the silver comparator. So it certainly does have really good efficacy. So to conclude, identification of local infection is paramount. Use the IWG-DGF guidelines. The guidelines are available there to help you and help you with your decision making. Try and use combined action to do biofilm-based wound care, looking at debridement, cleaning, and using a very good topical antiseptic dressing. And if you're in any doubt whatsoever with your patient, refer them to a specialist centre where certainly this information is well known to them. Thank you very much.
This was a neuroischemic infected foot that was deemed for a major amputation, but with the infection control and sucrose octasulfate impregnated dressings, we've managed to salvage the limb with a minor amputation. The previous speakers talked about the evidence behind infection control and the sucrose octasulfate dressing. I'm going to talk about the application in real life and the winning protocol that we're going to use for the larger scale observational study. I'm Mariam ALESSA, and I'm from Kuwait. So, we've conducted a pilot open label single arm observational study between the months of February and October in 2021 at the Diabetic Foot Center of Farwania Hospital in Kuwait to analyze the feasibility of a larger scale observational study. There were 2 endpoints or objectives. The primary endpoint was to assess the overall improvement of a diabetic foot ulcer using the sucrose octasulfate impregnated dressing. And the secondary endpoint was to assess the overall performance of the dressing by practitioners. Patients that presented with a non-infected diabetic foot ulcer at the sloughy or granulating stage were recruited, and they were followed up for a maximum duration of 12 weeks or until wound healing was achieved at an outpatient setting. Figure 1 shows you the type of wounds and the number of wounds we've managed in this pilot study. As you can see, we had 2 wounds located anterior to the malleolus, 3 post-transmetatarsal amputations, 1 big toe amputation, and 1 wound located on the medial aspect of the first metatarsal. It's also important to mention that we've managed all these patients holistically using evidence-based standard of care, which consists of the VIPs, vascular management, infection control, pressure offloading, along with the metabolic control and the local wound care. Therefore, 5 out of the 7 patients were utilizing offloading devices, while all patients underwent some form of debridement. 4 of the patients underwent sharp debridement, and 3 of the patients underwent autolytic debridement. All of the patients were previously managed with silver antimicrobial dressings, and apart from one patient actually where we applied an omega-3 dressing. And dressing changes were conducted usually every 3 days. We've recruited a total of 7 patients. All were male, between the age of 51 to 76, all with known cases of diabetes type 2. 3 had lower limb ischemia, and 1 had a previous kidney transplant. The initial wound area ranged from 4.5 centimeters square to 19.5 centimeters square, with a mean, as you can see, 42.4 centimeters square, as compared to the final visit, where the wound area mean dropped to 6.9 centimeters square. So that means that all wounds reduced in wound area size, with 5 out of the 7 wounds achieving complete wound closure. That makes 71.4%. The following slides are going to portray images of each case at the initial, intermediate, and final application of the sucrose octasulfate dressing. The first patient is a patient with a neuroischemic foot, and as we can see, this is the image 2 weeks post-transmetatarsal amputation. There's some slough on the wound bed. And we've also encountered with this patient a mild grade 2 infection according to the IWGDF classification, which consisted of a increase in local warmth and mild swelling in duration. So we decided to use the Urgo Clean AG for 9 days approximately until the signs and symptoms of the infection resolved, and then we continued with the sucrose octasulfate dressing. But as you can see here at the final visit, we still didn't achieve complete wound closure. Following that, we've utilized biological dressing to expedite the wound healing process. With patient number 2, that's another neuroischemic foot post-transmetatarsal amputation. And as we can see, the wound bed consists of some granulation with slough tissue. However, there was a high level of exudate with this wound, as we can see with the peri-wound maceration, especially on the plantar aspect, which we've dealt with secondary highly absorbent dressings. And this is the wound after 10 weeks approximately of the application of the sucrose octasulfate dressing. And the patient at some point complained of an unpleasant odor coming out of the wound. We've tackled that with a secondary carbon-based dressing. And we've used cadaxamar iodine dressings at some point during the 10-week interval to reduce the risk of infection. Patient number 3 had his wound located anterior to the lateral aspect of the lateral malleolus. This was a neuropathic patient, and not only was he a diabetic, but he was also obese and a smoker and with kidney failure. But we've managed to achieve complete wound closure within 4 weeks. However, after the 24th of May, we did record a recurrence, and we've managed to close the wound or achieve complete wound closure within 1 week using the same protocol. Patient number 4 is another post-transmetatarsal amputation of a gangrenous ischemic forefoot, and this is the wound 2 months post-amputation, and as you can see, it mainly consists of slough, but we've previously managed this wound with an omega-3 dressing, and we've managed to achieve complete wound closure within 7 weeks using the sucrose octasulfate dressing. Patient number 5 is another wound located anterior to the malleolus, and for this patient, we've used the sucrose octasulfate dressing for approximately 12 to 13 weeks to achieve complete wound closure. Patient number 6 has a wound located on the medial aspect of the first metatarsal. This was a neuropathic patient, but as you can see, we've also dealt with high levels of exudate, which we've managed with highly absorbent secondary dressings and local debridement. That fixed it up really nicely, as you can see from the intermediate visit. And we've managed to achieve complete wound closure within 12 weeks, I assume, or 10 weeks. For the next patient, this is a post-big toe amputation, and this picture is of the wound 2 months post-amputation. And we've managed to achieve complete wound closure within 13 weeks for this patient using the sucrose octasulfate dressing. So, to wrap everything up and summarize everything that me and my colleagues have spoke about, the winning protocol that we are going to implement on the larger observational study consists of, number 1, making a holistic assessment. Remember that you're not just dealing with the patient's foot, you're dealing with the patient as a whole. Number 2, treat any underlying factors that may impede wound healing, such as the vascular status or the metabolic status. Number 3, implement evidence-based standard of care, which consists of the VIPs along with the metabolic control, and the local wound care, which consists of local debridement and local wound treatment. For local wound treatment, if it is a non-infected diabetic foot ulcer, then we start with Urgo Start Plus. The sooner, the better healing outcomes you will get. And you can keep the dressing for up to 7 days, but it depends on the level of exudate. The higher the level of exudate, the more frequent that you're going to change the dressing. If it is an infected diabetic foot ulcer, then you would start the patient on antibiotic treatment according to your local protocol if it's deemed necessary. And you would start with the Urgo Clean AG, changing the dressing every other day or 2 until signs and symptoms of the infection have resolved, and then you switch to Urgo Start Plus until wound healing is achieved. And that's my talk. Thank you very much.
Thank you, Mariam. Thank you for all of you. So to proceed further, as Mariam has mentioned, winning tool, so that's patient assessment is really a key. So how we can do this? Education, education, and education. Education for healthcare professionals, for carers, for families, for everybody who are involved in the care of the patient. Train the trainers, link nurse programs, and then educate the patient, families, and carers, as I said before. So that's the key to make a chain for education, so everybody speaks the same language, and then implementing these tools, which our expert speakers have been mentioned, that's really very important, and involve the patient in the care as well. So that's really a way to go forward. So this is you can see here, our waiting area in one of our clinic, which is wound care clinic, and patient while sitting here can see what could be the consequences if we don't really take care or examine the feet on a regular basis. So these are the guidelines which you can download and then use in your daily practice. So before we go any further, I would like to ask if you have any questions for any of our expert speaker here. You can use the mic here and ask them the questions. Any questions from our speaker?